nice hospital in London, at the CWM hospital in Suva, Fiji. Okay. During his time at the Otago University, he was awarded the Credit Prize and distinction in removable prosthodontics. After his graduation, he worked in a private practice in New Zealand, completed his primary exams for the Royal Australasian College of Dental Surgeons, and then he moved to London, England, where I've had the pleasure of learning from him about his great experiences there, and when he got the bulk of his experience as a young dentist in working on the public sector there and developing his endodontic skills. In 2005, he completed his fellowship for the Royal Australasian College of Dental Surgeons and began the specialist training course at King's College in London. His research, entitled Microcomputed Tomography of Tooth Tissue Changes Following Root Canal Treatment and Post-Space Preparation, was published in the International Endodontic Journal during his final year and opened doors for him to lecture in the United States, United Kingdom, and across the world. So today, Dr. Ikram lives in Sydney, Australia, and he has a practice. And he is one of the dentists that I've had the pleasure with throughout 20 years in this industry to interact with. And he is really one of the most passionate about sharing his knowledge and interacting. And you can, if you don't know him yet, I highly recommend you follow him on his Facebook and Instagram pages, where he shares daily tips about endodontics and many interesting things. Among some of them he'll share here with us tonight. So Dr. Ikram will talk about tips and strategies for the treatment of endodontic pain. And it is my pleasure, once again, my friend, to introduce you and to learn from you tonight.
Thanks a lot, Fabio. I'm just going to bring up the talk for tonight. So as Fabio said, today we're going to talk about the tips and strategies for treatment of endodontic pain. So he very kindly introduced me. As he said, I'm from Christchurch and I did my undergraduate at Otago University. And then I moved to Christchurch where my parents are and did some work as a general dental practitioner there before moving to London. When I was in London, I did heaps of work on the National Health Service and got some skills in endodontics and restorative dentistry. I was thinking about doing restorative dentistry as a specialty, but endodontics won my heart, mainly because it was so difficult and I struggled with it so early. I think that's why I enjoyed teaching it. In 2019, a colleague was very kind enough to nominate me for the fellowship of the International College of Dentists. And in 2021, we released Endo Prep App, myself and William Ha, who's a training endodontist in Adelaide currently. Currently, I'm in Sydney and I work at a practice called Specialist Endo Crow's Nest. When I started this practice, the idea was to get dentists to become more enthusiastic about endodontics, teach them tips through social media, and also obviously treat patients for referring dentists. So we're going to talk about diagnosis and the prevalence of endodontic emergencies. So when I worked in London, one of the most common emergencies was, in fact, endodontic problems. And just to give you an idea, the College of Excellence, the American Association of Endodontists, has a group which I highly recommend you look into. There's a website, and this is all available online. But it basically says that the incidence of emergencies in dentistry is around 60% to 80% amongst all dental emergencies. So it's a lot of times when there is an emergency patient, there's an endodontic problem associated with a tooth or teeth. The ones we're going to talk about today, because diagnosis can be quite a dry subject, I'm going to try to simplify this to diagnosis of emergencies. So what are we talking about with regards to emergencies? We're talking about a pulpal diagnosis. So when you do your notes, when you see patients, you need to make a diagnosis on what the pulp status of that tooth is. And I know there's lots of different canals and multiple roots in some teeth, and we can have a challenge diagnosing it, but it's just a snapshot of what's going on based on your radiographic appearance and tests that you're doing and the patient's, possibly the patient's symptoms. So make a pulpal diagnosis. So in this case, the one that comes to mind is the symptomatic irreversible pulpitis. And then there's an apical diagnosis to be made after that, which can be osteitis, it can be symptomatic apical periodontitis as well, or it can be normal apical tissues. So you have to have both of these when you write up your notes. It's not good enough just to say the tooth was tender percussion and I started root canal treatment. That is not a diagnosis. So the obvious one is, as I said, symptomatic irreversible pulpitis, and then the other ones involve an apical diagnosis. Again, the pulpal diagnosis could be varied. So symptomatic apical periodontitis is when the patient has low-grade inflammation generally around the apex, and they say the tooth's a bit sore, and if I press on this buccal sulcus, it hurts a bit. That can be an emergency. Some patients come in just with worry, or they might be travelling soon and things like that. Apical diagnosis of acute apical abscess and also a pulpal diagnosis is also another common emergency. So this is where there's more severe inflammation and bacteria infiltrating the apical tissues. Swelling, pus is a common problem with these cases, and this is where we have a real problem, because these are the ones that spread along tissue planes, and if there's no sinus tract there, they will end up with facial swelling and possibly an acute problem. Also, our tests need to confirm that these are caused by an endodontic infection, because you can develop all sorts of interesting things that mimic endodontic disease. That may be, the diagnosis might be symptomatic apical periodontitis, but it may not be a bacterial cause. Things like clenching and things like that. So we need. This is why it's really important to give a pulpal and a periapical diagnosis in the notes. Just to give you a bit of an overview about the Endo Prep app that we created, you can actually find a lot of information on here. You can see the slide, the video going there, and we've got an area on diagnosis. So you click on the diagnosis there, and it takes you to the AAE page. And this explains diagnosis and the terms. So really recommend you read this, and the Endo Prep app is a nice way to summarize everything without having to go around different websites and search and things like that. So this takes us to our disease model. What is happening? And it's really important to know for emergencies what is happening. So first of all, bacteria from the oral cavity have to have reached the pulp. Endodontic disease does not occur unless bacteria can reach the root canals or the pulp chamber. So basically, there is a breach in the enamel and dentine, and it's very important to realize that you need to have that story in your head when you see the patient. Why did this happen and how did this happen? This is a really important part of how we diagnose a case. So basically, the bacteria reach the pulp chamber, and once they're in the pulp chamber, they actually cause a lot of inflammation, as you can imagine, and that is not always painful. It's quite often painful, and the patients will usually complain of sensitivity to cold. Sensitivity to hot is another one, because that tends to heat up the inflammation inside the tooth and then move the dentinal tubular fluid inwards towards the pulp, and then this is an increase in pressure again, and the patient gets that sharp pain. So cold sensitivity can be lots of things, because it involves movement of the fluid out towards the outside of the tooth, and the way that you can remember that is it's cold out. And sometimes that can be dentinal sensitivity or all sorts of things, just a hypersensitivity, but hot sensitivity is more commonly associated with pulpal inflammation. So what happens is, as there's an increase of pressure, the A delta fibers in the tooth that are the ones associated with sharp pain fire at a lower threshold. So some patients will come in and they'll say, when I breathe in air in the mornings, my tooth hurts. I've had to warm up a little bit of tap water so it's not so cold, or I can't drink my tea in the mornings without feeling excruciating pain. Or sometimes I've had patients say they put some fruit in the fridge and then they put it on it. It's a severe pain. There's a whole lot of sensitivity to temperature issues that are a result of increased firing of those A delta fibers at a lower threshold. There's also an increase in the pulp of these sodium channels that are resistant to local anesthetic. And so this is where our treatment comes in, and our reasons that we can use, techniques we can use to prevent pain and to treat these teeth. And there's a possible decrease in pH, although it's pretty difficult to study. And we were always taught at dental school that the local anesthetic doesn't work as well. pH is affecting the local anesthetic's ability to dissociate. But increasing the number of receptors inside the pulp with which are resistant to local anesthetic always makes a lot of sense in my mind. The prostaglandins that are released inside the pulp actually phosphorylate these resistant channels, and that increases the flow of sodium through them. So what happens is when you get this pulpitis, it's a result of inflammation, infection, and basically the increase in sodium channels that are resistant to local anesthetic. And that's basically called the hot pulp. So we're going to talk about this in a minute. So this is the scenario when we have the early part of root canal disease. In this part also, in this situation, bacteria are generally located inside the root canals. So as they try to get into the pulp and also the root canals, the body is fighting off the bacteria, and there's this constant flow of bacteria because there's a breach in the enamel, dentine, and basically the inflammation is fighting the infection. So you end up with less bacteria apically and more coronally. So if the bacteria are coronal in these cases, why do we even need to treat the tooth of the apex? And the answer is sometimes you don't. But in my mind, the tooth has to be in a situation where it's not going to receive some kind of major restoration to do that. Because we know that root canal treating teeth with a pulpitis and minimal apical inflammation or no apical inflammation has a good success rate in general. Because the inflammation and the bacteria are inside the root canals of the tooth. And if we're able to clean out the root canals and remove the bacteria and the pulp tissue, which is the food for the bacteria, then we have a good success rate. So here's a couple of cases where I did do a pulpotomy. So this is a very appropriate case to use a pulpotomy technique. This is using biodentine in this case. The patient has a dens invaginatus, and it's the lateral incisor. You can see the central incisor has a periapical lesion already, and it has another, has also got a dens invaginatus. So with this tooth, you can see that if I root canal treat the tooth and try and plug the apex, I'm going to end up with a situation where the root canal possibly doesn't develop, or the root doesn't develop in this patient. This patient was actually in her sort of around 12 years old, so a late developer, and obviously has lots of these dent issues. So what I did here is I actually was able to see in the lateral incisor there, you can see I was able to remove the coronal pulp, which was inflamed. And then I was able to close that with, just wash gently with some 1% sodium hypochlorite just to get rid of that coronal pulp. And then when I saw the fresh pulp tissue, so it wasn't scarlet or bleeding profusely, I just placed some biodentine, followed by a little bit of IRM and then glass ionomer. And then after the glass ionomer, I just placed a little bit of Comsyn. So basically this is designed to prevent bacteria getting in. And you know what, these cases are really lovely because the reason why this tooth isn't, the apex isn't closing is that the bacteria are coming through that dens defect. And if we remove the dens defect and restore, then the tooth can develop normally. So you can see here's the central incisor that we treated that because it has a periapical lesion and necrotic pulp. But we got the diagnosis on the lateral incisor nice. And there's lots of nice, healthy tissue at the apex that have formed the apex. So you can see 6 months later, and then 4.5 years later, you can see the lateral incisor has fully formed. So on the central incisor, you can see there's also been healing of the lesion. Here's another case. Again, the patient was a young patient, 9 years old. They had caries to the pulp on their 3-6. When I took a periapical radiograph of the apex, the tooth hasn't formed fully. It's pretty close, but it hasn't formed fully. And I thought to myself, I'll just try and preserve the vitality of this tooth so that we can get apex closure. And if the patient needs a root canal treatment later, then we can do it when the apex is closed. They're older. The treatment was done under general anaesthetic. I'm one of the few endodontists who does treatment under general anaesthetic in New South Wales. I think I might be the only one. So post-operatively, under general anaesthetic, this was the situation. This was using MTA. So I used MTA in this tooth, and then the review was done by the general practitioner. I took an OPG, so I had to crop that one. But you can see there's root formation and healing of that area. So you can do pulpotomy treatment on some cases, but you'd need to have a situation where the tooth was not going to be massively restored. Because, as I said, root canal treatment to the apex has a high success, and anything we do with pulpotomies will perhaps have a lower success rate. If you look at the literature, because there's so much variation in diagnoses, there's so much variation in materials, and we've only obviously recently in the last 30 years had MTA. Before that, we had calcium hydroxide. So the calcium hydroxide is a factor. It's hard to place, and that's traditionally what we basically have got have had calcium hydroxide traditionally, and as I said, it's more difficult to place. So the hot pulp, we got heaps of requests to talk about the hot pulp tonight, and so I'm going to talk about it. So we talked a bit about prostaglandins. So it stands to reason if we block the prostaglandins, we can perhaps get a better result without inferior dental block. And this is a great study with Paul Abbott from Western Australia. So they basically published in 2010. This has been around for some time, this concept, and I've been doing a bit of reading on this recently. And they basically just gave patients with irreversible pulpitis, so hot pulp. They gave them either placebo 1 hour before, either 600 milligrams of ibuprofen or indomethacin. And basically the patients with ibuprofen and indomethacin significantly had a significantly increased success rate with an inferior alveolar block. So this is something to remember for your patients that ring up and say, I've got sensitivity to hot, it's really bad. And you guys are the people who will know this, because you will have done that restoration a few days ago, you have done it a week ago, whatever it is, and you will know that patient. It's people like me who get the call and the patient's not quite sure, and they come in and then they tell me the story. Whereas you guys have placed that restoration. So it's a really handy tip for you guys to give these patients, if you can, ibuprofen. Of course, not every patient can take ibuprofen, but if you guys know their medical history because you've seen them before, then you are able to communicate with them and prescribe this beforehand. They can take this at home. Or if they get to the surgery as an emergency, here's another tip. You can use liquid capsules. So these are Nurofen's Advanced, but there's a few other ones. They get, once the patient takes these, they probably take about 40 to 50 minutes to work. And if you're getting Advil ibuprofen sodium, they take about 25 to 30 minutes to work. So if the patient comes in and you diagnose that pulp and you check that they're able to take Nurofen or ibuprofen, then you can get them to take these medications, and you can get them to perhaps go downstairs and just relax, or even in the reception area, and then you can get them back and deliver the block with a higher success rate. So how do I anesthetize hot pulps? So the symptomatic irreversible pulpitis. Well, you can offer them ibuprofen, or you can offer them a fast-acting ibuprofen, so ibuprofen 1 hour beforehand, or a fast-acting 30 to 40-minute ibuprofen. I use articaine. If the patient's in severe pain, I'll use articaine as an inferior dental block. There's not that much evidence regarding articaine as a block. Some people say it's great, some people say it's not that useful, but I think that it's just a good one to give patients. And I've certainly found when I have used it in these severely sensitive teeth that I've had a better success rate. And some people have mentioned this, but it's not really well discussed. What is well discussed, though, is that buccal infiltration with articaine has a very high, increases the success rate of your inferior alveolar block. So this is what I definitely do, infiltrate with articaine, which is 1 in 200,000 adrenaline. So it has less adrenaline than lidocaine. Articaine actually can diffuse through nerves. It can diffuse through tissue much better because of the thiophrene ring. Traditional anesthetics like lidocaine have a benzene ring, and they don't diffuse quite as well, so that's the reason why that works more effectively. Then I'll do a lingual infiltration, and the reason why I do a lingual infiltration is perhaps preparing the tooth for the patient for an interligamentary, and also just to reduce the pain of the clamp, or if there's any movement lingually, there's sometimes a bit of sensitivity, and I just want to reduce that as much as possible. There's nothing worse than having to go back into a patient and keep doing more injections, and the patient thinks you don't know what you're doing and basically loses all confidence. You just get this straight up, I just give all these. The next thing I do is wait 15 minutes by the clock, because you're always keen to start. The patient's keen to start, get started. They don't know why you're pausing. just tell them it's going to take now 15 minutes and we'll listen to some music or we'll do something for 15 minutes, and watch the clock on your computer or your clock in your office, and basically just make sure that everything is nice and slow and you've waited that time, because there's nothing worse than starting and then having to do more and not quite sure if you should wait or just wait that full time. Now, if the patient has sensitivity to cold, you would test with cold again. If they have sensitivity to hot, you would have to test with hot before starting. The way that you do a hot test is actually you isolate the tooth and you just put some hot water from a syringe. So what I do is I get my nurse to go and get some really boiling water, and I just dilute it myself with cold water, and I put it into a syringe, one of those plastic ones, not the irrigation syringe, which is too narrow. I put it in the plastic one with a thicker tip, and then I just basically inject the hot water onto my arm slowly. And if I can feel that the water stings a bit, then this is a good scenario. You don't want to get burned, or you don't want to think it's ineffective. So what I do is I do that, and then what I do is I pull the hot water on the tooth and leave it there, and then get the nurse to suction far away so that the tooth will be pulled in hot water, because this is what causes the inflammation to go back in, and the pulp fluid, so the dental and tubular fluid to go back into the pulp and cause pain. Once you've done this, if the tooth is not responding with the same way that they came in with, then you know the anesthetic is working. It also gives you confidence that the patient is happy for you to start. Because again, there's nothing worse than starting and not being sure if the patient was happy with that or not happy with that. It's best to try and elicit symptoms before you start. If you cannot get any, it's like an acknowledgement that you've done your best and you're going to start. If all else fails, of course, periodontal ligament injection is good, and then you've got the intrapulpal as a backup. But again, if you had to give an intrapulpal at this stage, it's a lot better to give it when you've done all this beforehand than it is to do it without giving adequate anesthesia, because it is uncomfortable. And usually, I'd say to the patient, you'll feel something here. You'll be aware of this discomfort. And the way you give an intrapulpal is you place. It's the opposite of irrigating a root canal. You place it in the root canal, the anesthetic, as firmly as you can, and push the needle down. Usually, I use the other hand. Just push the needle in, bend the needle, and just push it down. And then I'll just inject quickly, but in short bursts. Bang, 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 bang. The patient will say, "Ooh," and then eventually, and then when they stop getting that minor discomfort, then you just force the anesthetic through. And what that does is it basically causes necrosis of the pulp. This is a paper by Kun, who did a systematic review. You can read, again, Journal of Endodontics, and they did a review on whether articaine works as a block and whether it works as a infiltration, and they found that articaine is superior when used as an infiltration buccally to anesthetize these hot pulps. So here's another interesting case that I saw a few months ago, actually. So this patient had pain with hot liquids, and basically they had got this really interesting situation where they'd had a screw placed during orthodontic surgery into the root of the 3-6, or the first molar tooth. But the pain was sensitive to hot, and they weren't quite sure where it was coming from, as is mostly the case. But they've seen another endodontist who identified 3-7 as having an apical lesion, and 3-7 certainly has got an apical lesion. But 3-7 also had no response to cold, and 2-6 also had no response to cold, and 3-6 responded normally. So we could pretty much guess by the tests there that and also 3-6 was not tended to percussion. So although it had a screw in it, 3-6 was off out of the picture, because it responded normally to cold and it wasn't tended to percussion, and there was no periapical lesion around 3-6 on the scan, on the CBCT scan, or the radiograph. So you can see there's a periapical lesion associated with 3-7, and you can see that there's it's very close to the inferior dental nerve, and you can see there's a 2-6 has got a deep restoration, but no periapical inflammation. And again, 2-6 is not tender percussion. So what would you do? Well, in this case, we knew that 3-6 was infected and necrotic, and anything can happen there. But what I ended up doing is deciding on anesthetizing the 2-6, which didn't respond to cold. And then I got the patient to drink hot water, and they weren't able to feel any pain anymore. And so 3-7 is necrotic, and it needs to be root canal treated, but it's not the cause of the hot sensitivity. So just by numbing that 2-6 and getting the patient to drink water, hot water, basically eliminated that from the as a cause of. It showed that it was the cause of pain. It basically eliminated that pulpitis by doing the anesthetic, and then the patient was able to drink hot water in front of me. And so then we ended up treating 3-7 because it was necrotic and had a periapical lesion, and 2-6 because it had a symptomatic irreversible pulpitis. And so the diagnosis for the 2-6 would be symptomatic irreversible pulpitis associated with normal periapical tissues, because it has no tendinous percussion or radiographic lesion there, and we can see nothing that's wrong apically. And again, if you take a cone beam with these teeth don't show any apical disease quite a lot of the time, because it hasn't had the inflammation there outside the root canals for long enough. That's quite common in pulpitis, but not always the case. The 3-7, on the other hand, is obviously infected, and although that can be a cause of pain, it's not usually associated with hot sensitivity. It's got such a large lesion. Although, again, you need to do the tests to assess that, because it can, even a tooth with pulpitis can have a periapical lesion. So here are the root canal treatments completed, and the patient has a deep restoration on 3-6, and this is almost certainly going to need some root canal treatment at some point, but at the moment this is okay. I do get questions a lot about use of steroids for pulpitis. So when we have steroids for patients, that suppresses the inflammatory response, which, as I said, is part of the problem with pulpitis. However, there are a few things I outlined earlier on, like there's a defect in the enamel and dentine. If you don't treat that, there's constant flow of bacteria. So there have been some studies done using 4 milligrams of dexamethasone, and here's one. And this is basically suggesting that this works well. So I would say this is real lockdown dentistry. Last year I had a number of friends contact me from the UK who were having patients with pulpitis, calling them up, and there was no dental practices open, or very minimal dental practices open at that time. So what happened was they some of them did end up prescribing dexamethasone. But it would be my last resort, because we should try and treat these patients and remove the pulp. If we shred the pulp coronally, we will actually remove the pain. If we're removing a bulk of the microorganisms and we're shredding the pulp tissue and we're reducing the inflammation and we're closing that defect that has to be there for them to reach the pulp, we are going to get reduction of pain. So treating the tooth is always better than prescribing medications, but sometimes we have to prescribe them. We also obviously need to find canals. If we don't find the canals, it's very difficult to get patients out of pain in general. In pulpitis cases, you can do a pulpotomy a lot of the time. Again, if you remove a chunk of the pulp tissue and you reduce the inflammation by doing so, then you will get some kind of healing, and also the pulp coronally will not be able to function, and then the patient won't have that severe sensitivity. So there's a variety of ways to locate root canals. This one is an MB2 of an upper molar tooth. I use sable C. You can see it stains the protein around orifices of the canals. So I was able to locate the MB2 using this method.
DNB sử dụng phương pháp này.
Sable C can also be used to locate cracks and visualize these a bit more clearly, and you can see that photo. I saw the crack there, and then I stained it with Sable C. You can use oxygen bubbles, so you can see what happens here is hypochlorite on the pulpal floor, and watch for where the bubbles are coming from. You need good magnification and illumination to do this. I suggest using an operating microscope, or 5 times magnification and above is the best. Is best, and illumination as well. So the when we've located the MB2 there, you can prepare it. So what I was doing in this case was I was looking for the MB2 and I couldn't quite see it, and I just used those bubbles, and it's quite obviously there's hypochlorite interacting with the pulp tissue, creating oxygen bubbles. So when we're looking for MB2, we trough. Here I'm using an endotracer burr, just pecking away at the where the MB2 should be, and I can see that white dot come up. This is my favorite technique for finding the MB2 canal. So this is just looking for calcified canals in general, but the MB2 is obviously the one that we all know and love. And you can see here, I'm just going to put a size 8 C-pilot file into the canal. So you can see that white dot, that's the MB2. This is actually the foldable tube on my microscope. So I have this microscope, which is a Zeiss Staro, and I got that last year. And it has a foldable tube which brings up makes the light in the tooth greater and brings the patient closer to the lens, and also doubles the eyepiece magnification. Use flicker switch. That's very good. So the eyepiece magnification for the operator is increased, but for the screen and the surgery for the nurse is not increased. So that's actually quite handy because you want to see more detail, and the nurse wants to see a greater field of view. And here's me accessing the root canal with the wavefront gold. Again, it's a reciprocating system, so this is a useful system. You can reduce the strain on the file. And here's the root canal prepared. The EndoPrep app has a feature that myself and William came up with, which is essentially an MB2 guide. So what you do is you prepare the 3 main canals. This was a patient that was referred to me to locate some calcified canals. You can see I've prepared MB1, DB, and palatal, and you can see it's telling me the MB2 is about there, which is where it is. You can see that little white dot. I've troughed for it, and then you can see that the MB2 is present there, and I've filled the root canal. MB1, 2, DB, and palatal, so you can't see up to the left. And here's a slide from my friend who was using the app, and she's in rural New South Wales, and she thinks it's good for locating the MB2 as well. So medications to place inside root canals. Calcium hydroxide is the gold standard medication that we all know about. Now, why is it the gold standard? I would say that it's a gold standard even for vital cases, and I'll tell you why. So a lot of the studies talk about it being antibacterial, dissociation into hydroxyl ions that act on the lipid transport medium on the cell wall, creating a lipid-free radical, destabilizing the cell and causing hydrolysis of the cell or lysis of the cell, and increasing pH. But by increasing the pH, it actually denatures proteins. So when we're looking at vital pulps, and we've shredded the pulp, and we want to clean out as much pulp tissue in the tooth, because the pulp tissue is the food for the microbes. So if you don't clean out pulp tissue, it's essentially like having food for the bacteria, and then they just regrow because they've got lots of food and they regrow, and then you get apical periodontitis again as the population inside the root canal rises with the food source. So we're trying to remove as much tissue as possible. So with calcium hydroxide, even for vital cases, this is very useful, because what it does is it basically denatures that pulp tissue. So when you use sodium hypochlorite in the second visit, if you're getting the patient back in, then it will actually just work faster on that pulp tissue. It's also known to hydrolyze the endotoxins in the root canal, and again, it's thought to be more beneficial with regards to root canal retreatment cases because of that, where we have lots of endotoxins. And there's was a study done by Hasselgren, the denaturing protein allowing sodium hypochlorite to dissolve it easier on the next visit. So I'd say, as I said, you get the isthmus between the root canals where there's pulp tissue, and if you use calcium hydroxide, this is going to help to remove that pulp tissue in that isthmus if you get it in there. How do I place it? I use these Navi tips. Ultradent make these Navi tips. They're very handy. I've got the stopper on there, about a millimetre from the the working length, and if I just inject it. So as you can see, the stopper is not reaching the reference point. So if I find that happens, then I just work it down with an activating tip or maybe a file. But this is more effective. This kind of injection technique is far more effective than placing it with a file or a paper point. Studies show that, because when you place a file with the calcium hydroxide, it just goes coronally and none goes apically. So we're going to continue on with our disease model. So after the pulpitis has occurred and the bacteria is still coming through that defect, what you get is that story the patients all tell you. My tooth was killing me for a few days. I was taking Nurofen. I was doing everything. I was climbing the wall. And guess what? Today, it feels all normal again, although the tooth feels a little bit uncomfortable to touch. But I don't have to warm up my water. I can drink my coffee. And everything's kind of okay. And they sort of have this relief of pain. I get these patients coming in all the time. What's happened there is the pulpitis has occurred, the pressures occurred, the bacteria has overwhelmed the pulp, and the pulp's basically going to be mostly necrotic now. Once the necrosis starts, the immune system inside the tooth is basically gone. Obviously, I'm talking generally here because there are a variety of root canals in the tooth, and lateral canals and things like that. And then, so once the immune system is not working well in the tooth to defend it from the bacteria, then the bacterial population rises significantly, and the toxins exit the apical foramen and lateral canals if there are any. These toxins then increase the endotoxins and the bacterial products that exit the tooth cause the inflammation in the periradicular or periapical tissues. So in other words, there is an increase in inflammation outside of the tooth, and that's when you get the patients coming and say, yeah, the tooth is uncomfortable when you press on it. You see a periapical lesion. That is a periapical diagnosis. Symptomatic apical periodontitis, or asymptomatic if the patient doesn't feel that there's anything wrong, and you can see that there's something wrong with the radiograph of the cone beam as well. So that leads to a feeling of pressure under the tooth or slight discomfort. If the bacteria remain inside the root canal just sitting there and the toxins coming out, then you get this symptomatic apical periodontitis, the stalemate, the bacteria in the root canal, the immune system's under the tooth waiting for those bacteria. There's very little bacteria, if any, in the periapical tissues. This has been shown by Nair. And the bacteria, it's a standoff. They're not coming out, the immune system can't go back in. There's no blood supply to let the immune system back in. The bacteria aren't brave enough to come out. But if the bacterial level rises further, or there's a certain type of microorganisms involved in the root canal, then you get an acute abscess. So we don't really know why bacteria decide to exit the apical foramen and actually enter the periapical tissues, but it's probably got to do with population and the biofilm makeup and a whole lot of other things. Like why do animals leave their home and search for more land, or why do humans do that? Because they run out of resources and they decide to move into other areas. So this is possibly what happens, and then once that happens, you get like a full-on infection under the root canal, and that's when they get this swelling and this pus formation often, or sometimes it's just fluid formation, and the patient ends up having a really severe swelling. And basically, our treatment has to be aimed at symptomatic apical periodontitis has to be aimed at reducing that swelling under the tooth. So that's creating some drainage through the tooth, removing that pulp tissue as the food. For an abscess, it has to be about draining a lot, because this patient is going to have a spreading infection if you don't remove the pus. The other thing about these cases with the apical periodontitis, the patient can feel discomfort is reduce the bite. If you reduce the bite, sometimes I've seen patients with emergencies with either of these conditions, and I just reduce the bite and tell them to take pain relief, and I'll see them again when I've got a spare minute, maybe the next morning or whatever. We fit them in. So this is a scenario where we can help the patient just by adjusting the bite. That will take the pressure off the tooth, and that really, really helps. It helps a lot more than you'd think it does. The problem is that the bacteria are covered in a biofilm and attached to the walls of the root canal. And they're in aggregates, so aggregates are the same species and co-aggregates in different species of bacteria all on top of each other. It's like It's like a colony of microorganisms. So we need to break those biofilms up. But how can we do this? Well, we do it with our irrigants and medicaments. We do it with files, but the files don't touch much of the walls. We know that Peter's studies that 35% of the canal remains untreated most of the time, or maybe even more. And the most commonly used irrigant is sodium hypochlorite. So what does this do? Well, it basically is an unstable product, which is why you can't mix it with things. Remember the old adage, you don't mix it with EDTA, and don't mix it because it reacts with everything. So you want it to react with the pulp tissue, the biofilm, and you don't want it to react with the dentine wall, but that's impossible to prevent because the dentine wall is there. It's in a positive state, so the chlorine ion is in a positive state and wants to change that. So it interacts with everything. It's a tissue solvent and biofilm solvent, and it's also antimicrobial. And it also it denatures proteins. So it degrades fatty acids and permits penetration of the hydroxyl ions. It creates hypochlorous acid, which degrades amino acids or proteins, and solvent effect. It basically creates chloramines with a tissue interaction, and this impedes cell metabolism. So it's an antimicrobial agent, has a very high pH, similar to calcium hydroxide. Calcium hydroxide has a higher pH, but this is more instantly acting. So it's available in lots of concentrations. In Australia, we have 1% Endosure, 3% Canal Pro, 3% Clausid V, and Clausid Surf, which you saw. So what I find interesting is that originally, and if you'd seen my talks previously, I had discussions about percentages of hypochlorite, and whilst that's quite important, for example, a 6% solution will dissolve tissue 6 times quicker than a 1% solution if they're made the same way. Actually, what I'm finding now is the surfactant in that product makes a difference. So something like Clausid Surf with an improved surfactant, that basically lowers the surface tension. So what's lowering the surface tension? Well, surface tension is where we've all seen this, where we've got a leaf and we get droplets of water on the leaf and the droplets just pool in like round droplets. That's high surface tension. You don't want that. You want a smear of hypochlorite over the pulp tissue. You want it to run all around it, not have little blobs of interaction. We want to increase the surface area that's interacting. And so something like Clausid Surf does this. So the improved surfactant. So I would have different types of sodium hypochlorite in my surgery. I have ones with improved surfactant for vital cases, for single visit cases, and ones that have not got that for multiple visit cases because you're using the calcium hydroxide and that denatures the tissue anyway. So if you're not going to use calcium hydroxide because you're doing a single visit or you're treating a vital case and you really want to remove that pulp tissue, then I recommend something like Clausid Surf with that surfactant just to make the dissolving of the tissue much quicker. There's no difference in the antimicrobial effectiveness of any of these products, but there is a difference in the tissue dissolving and biofilm dissolving speed because of the surfactant and because of the percentage of hypochlorite. So as I said, a 6% solution of sodium hypochlorite will dissolve tissue and biofilms generally 6 times quicker than a 1% solution. However, the surfactant does change that, and heating will also change that too. So heating it you can do, but don't heat it in a syringe and then put it in the patient's mouth because by the time it goes down the needle and into the root canals, it's 37 degrees or close to it, and it doesn't have any increase in temperature. What you need to do is heat this inside the tooth. And I use one of those down pack tips, the warm vertical condensation unit. I just heat up the sodium hypochlorite. The other thing that you can do is you can activate it, but again, that has its own problems with heating up inside the tooth. I much prefer to use the down pack tip. The other question is that I get asked a lot is how long shall I irrigate the root canal for? How long do I need to irrigate for? There was one study that was done that was fairly well done out of Loma Linda University by Rita Mozo, and they basically just put dentine slices with an E. faecalis biofilm on the slice and then just irrigate it straight. for a certain amount of time, and the slice that got dissolved quickest was the 5.25% sodium hypochlorite, and it was done for 40 minutes. So that's the minimum time you have to irrigate for. 40 minutes in total. Of course, if you're doing a single visit case, you'll be irrigating much longer than that. If you're doing multiple visit days, it's even longer. Generally, in my practice, I'll be booking out 2 hours for single visit cases. So you do a lot of irrigation. And remember, in this study, they did not activate the irrigants, so that plays a role as well. And they didn't heat it. They just straight irrigated on top of these slices. So they had the advantage of straight irrigation on top of a biofilm, which is an advantage. We don't get that luxury, unfortunately, most of the time in endodontics. We're dealing with lateral canals and fins and things like that. But they also didn't activate the irrigants. So I basically just use as high as I can. But now, as I said, I've started using surfactant containing hypochlorite to improve the tissue dissolving capacity in vital cases. The other thing I do routinely, especially with wide canals, is activate. I use the eddy, so this is a good one for activation. You can see it's a sonic activation technique, and you can see the swirling and movement of hypochlorite. So, as I said, you cannot touch the sides easily with your file, and unless the canals are narrow. And in this case, the canals are wide. You're really not going to get much debridement on the file. So you need to work the hypochlorite round, and I use the eddy endo. The other one I use quite a lot is the endo activator, which is more transportable, and you can just use it, carry it around, and I can take that to general anaesthetic theatres. When I go, we have a general anaesthetic theatre across the corridor. I'm lucky enough to have that in Crow's Nest where I work. Of course, we always like to try and remove the pulp, and we can do all this fantastic filing and activation. But if you're lucky enough to get it out in one piece, well, there you go, job done. So this patient has an acute apical abscess associated with a necrotic pulp, and they're an emergency patient. So I'm going to talk about treating this condition now. So the patient attends for an emergency appointment. They say they've got pressure under the tooth. They've got swelling and they've got pain. And they've had to take analgesics. That's something I look for in the history. Always listen to what your patient's telling you. If they start saying they're taking painkillers and they've been up at night and taking painkillers, this is a giveaway that it's quite severe. It's not just a minor thing they're suffering from. Patients generally don't like to take painkillers. So emergency treatments aim at reduction of that pressure and to stop it spreading along tissue planes, which is where the pus can go. So what we do in these cases is we drain. I like to drain internally via the canal, but as you know, a canal is only so big, and it's unlikely you're going to get a lot of drainage from within the canal. And so draining internally and an incision of the swelling as well as that. That's my ideal scenario. If there's nothing to drain, incise, if there's nothing to incise, no swelling that's obvious, it's sort of in the cheek or in the lip, and you can't make a drainage point. I will open up the root canal, and I will palpate the buccal sulcus and try and pump the pus through the tooth, just gently, and hopefully that comes out. And often, if you just patency file size 10, you will create a drain. So after I open the tooth up, you can see the purulent pus discharging, and you can use these capillary tips, a lower lock suction tip, and it sits on the end of the suction, and you can suck that out through the end of the root canal. Because again, if you can get that out, that's what's creating the pain, that's what's going to spread to areas, that's what's... Essentially, these teeth are teeth where the inflammation is so rapid in the tissues that your body doesn't have or the patient's body doesn't have enough time to create a sinus tract, which is a drain. The sinus tract is a drain, and if there's a chronic inflammation that just creates its own sinus tract, then there's hardly any danger of getting spreading infection. So definitely don't prescribe antibiotics for draining sinus tracts, because they're not going to go anywhere most of the time. We're going to talk about that in a minute anyway. So there's my root canal treatment. Another bit of information, a tip regarding this kind of situation is that basically the patient has to be warned that this tooth is going to be sore afterwards. it's normal to get pain. There's a couple of things you need to really nail down with patients. You've had the treatment, but this tooth is going to be sore. Why is it going to be sore? Because I've treated the root canal issue that you had, which was the reservoir for the infection. However, the inflammation or the cells that are inflamed around the end of the root are still inflamed for a few days until they realize there's no bacteria or less bacteria in the root canal, and then you'll get healing of that irritation or inflammation under the tooth. And this really needs to be hammered home to the patients, because they think if they've had root canal treatment, they'll be better the next day, and you'll get calls. And the other thing you can do is, again, relieve the bite, suggest pain relief. The phoenix abscess is something else that we all find ourselves facing. It's where you have a treatment that you start, it's asymptomatic, and you say, yeah, this will be good, I can just treat this tooth, and then you clean it out, and the patient has a swelling a few days later. So these are treated in the same way. Basically, the idea is the phoenix rising from the flames and coming back. So what you've done there is you've extruded debris during the preparation, and the patient's gone from a 0 to 1 out of 10 pain to a 7 to 8 out of 10 pain, and they went to see you to not be in pain, and now they're in pain and they're unhappy, and that's a difficult scenario. So again, drainage through the tooth, incision, and prescription of anti-inflammatories, and it will calm down. It takes a maximum of 7 days. I've not had a patient that's had a swelling or a pain in their tooth that's been severe for more than 7 days ever, I don't think, unless it was something to do with the bite or the high contacts and things like that. That's more indicative of that. You have to tell these patients that it'll be sore. And I usually say to patients, I give them the analgesic regime, and then I let them know when to call me. And I usually say, call me 6 days afterwards, so I tell them the day and the time, and they stick to that. If you just say, call me if it's uncomfortable, they'll call you in 2 or 3 days, and then you'll just say it's normal, and then I'll say it's not. So regarding an analgesic regime for your patients, what do we prescribe? Now, this was a very discussed topic when I was a general dentist. It was discussed a lot in the staff room at lunchtime. What do you do? Well, there is actually a table on this. It's called the Oxford League table of analgesics. And basically what they've done is they've ranked these analgesics in order of effectiveness. So you've got, at the top of the table, you've got ibuprofen, and they've combined the 600 milligrams and the 800 milligrams. Now, 600 milligrams you can take up to 4 times a day. So that's 2,400 milligrams. You can take the 800 milligrams obviously up to 3 times a day, same maximum dose. So I recommend 600 milligrams because you can do that 4 times. Then you've got diclofenac, then you've got the Apanidine 4, paracetamol, and codeine. So the numbers here basically mean what's the percentage of patients that had half their pain reduced in that study. And for ibuprofen, it's 86% of patients. So that's a very high number of patients that had their pain reduced by half for post-operative pain and inflammatory pain. And the number needed to treat, or NNT, is the number of patients that you need to treat to get a 50% reduction in pain. So you need to treat 1.7 patients before you get a patient that says they had pain reduced in half. So if you look at all the other combinations, they're a bit less effective than ibuprofen alone. So ibuprofen, because of its blocking of prostaglandins, is an effective anti-inflammatory, and that's what I recommend straight away. Paracetamol itself is not that effective, as you can see. Codeine, the one that everyone talks about, and the reason why codeine isn't thought to be that effective is it's got very little interaction on inflammatory or action on inflammatory pain, the prostaglandins, the inflammation mediators. So codeine also causes constipation. So if you prescribe codeine, the patient will have a sore tooth and a sore somewhere else, and they won't be very happy. So don't prescribe codeine straight up. Placebo, and then now you've probably heard about these combination tablets. You've probably all heard about them being sold them by the pharmacist, or the patients are taking them. Now, ibuprofen and paracetamol is quite effective if you take them together. However, paracetamol is quite a toxic drug if you take a lot, and the recommended daily intake is around 4 grams per day. It's responsible for a number of liver problems, and obviously it's a very easily overdosed drug because it's in lots and lots of products. So what I recommend is not take the dual tablet. Don't take the tablet that has both of these medications in, because the patient that loses a run of things, they say, I've taken 5 tablets. That doesn't tell me much. But if they've taken Nurofen, so I'd say take Nurofen 400 or 600 milligrams and 1 paracetamol. That's what I recommend. 600 milligrams, 400 milligrams. Depends on how severe the pain is. But if it's really severe, I'd say 600 milligrams and 1 paracetamol, and from different boxes, so they know what they've taken. Don't take anything else. You don't take like headache medication from something else, because otherwise they get more paracetamol dose inside them. So this is something very important. So ibuprofen and paracetamol work quite well together, but it needs to be monitored by the patient. It's so easy to overdose in that. So this is our patient asking us why, if this is a bacterial problem, why can't we just take antibiotic tablets? And the answer is, well, there's so much going on in apical periodontitis, which is not a traditional infection. For a start, the bacteria are largely contained within the root canal most of the time, and there's a defect there in pulpitis. So in pulpitis, or many times in chronic disease, there's a defect in the root canal, a defect in the enamel and the dentine, allowing the bacteria to access the root canal. So if you don't close the defect, then you've still got a rush of bacteria coming in. So antibiotics aren't going to help a situation where you've got a rush of bacteria coming through that defect. The other thing is that for this reason, you shouldn't really prescribe antibiotics for pulpitis, because, as I said, the bacteria are largely inside the root canals only. There's very little in pulpitis cases outside of the root canal, generally, and I'm talking generally speaking here. In symptomatic apical periodontitis, again, the bacteria are within the root canal and there's very little outside. The patient may have some discomfort, but this is not a reason to prescribe full systemic antibiotics. In acute apical abscesses, they are outside of the root canal, or some of them are. The reservoir of the infection is inside the root canals, but there is an infection outside of the root canals in this situation. So this is where you could prescribe antibiotics. So when would you? So you can see on the Instagram poll I did that most of the dentists said you don't prescribe antibiotics for that situation, and I'd be agreeing with them. You don't need to prescribe antibiotics if you've got drainage. So if I've got an incision, a drain, and I open the canal up, I'm not going to prescribe antibiotics for the patient. I would only prescribe antibiotics for a patient if they were immunocompromised, had lymphadenopathy, malaise, or a spreading infection. That's when I would consider prescribing antibiotics for that. Because if you've got an open pathway for drainage, the pus will drain out through that pathway, preferentially to going along some tissue plane. But it's when you have that swelling and it's going to drain, you don't want it. It's where you need to look at prescribing antibiotics. And consider the systemic signs of infection as well. So if the patient has systemic signs of infection, they need systemic treatment as well. So this is why I say spreading infection, malaise, immunocompromised patients, lymphadenopathy. These kind of signs, not just a localized swelling around the tooth. So I thought I'd finish with a little tip. This is a bit unrelated to the subject tonight, but a lot of dentists contact me through Instagram and Facebook and say, how do you get your pulp chamber nice and clean? I use some citric acid. So here's a case I treated recently, tooth 36 with a necrotic pulp. I was able to use the citric acid 20%. You can see it's an orange color as a substitute for EDTA. After I filled the canals, I cleaned it up again with some citric acid, and you can see it's nice and clean there. I buffed it with a stainless steel burr, and you can see there's the cleaned up access, and then there's a restored root-filled tooth. So citric acid is certainly something to look at. Getting Ultradent the Ultradent people sell this also. So thanks everyone for showing up tonight and taking some of your time out to listen to the seminar. I think it's a really good thing that you've done this. Please keep showing up. You didn't do this today just for your own practice or your business. You did it for your patients, and you did it most importantly for you. you've done it for yourself to make sure that you can offer the best services you can to your patients, and that is very admirable. So thanks for dedicating your spare time to listen to this talk. If you have any questions, I'll take these now, and I'm contactable through the Specialist Endo Crow's Nest Clinical Hacks page on Facebook, on Instagram at Specialist Endo, and if you want to email, it's info@specialistendo.com.au. So thanks once again for listening, and thanks to the guys from UltraDent for organising the seminar.
Excellent. Dr. Omar Ikram, thank you so much once again. Wonderful presentation, of course, once again. We will now take your questions. Thank you for participating, for joining us, for all 1,700 of you that joined us today for this. We do have a large number of questions, and each time I look to the side here, there's more. So here's the way to upload. If you see some questions that you like there, so if someone already asked the question that you would like to ask, please check for that too. We will do our best here to answer as many as we can, and if we cannot answer all of them, I would suggest you stay tuned. You see the link there on your screen for Specialist Endo on Instagram and on Facebook as well there. Dr. Ikram is always sharing tips, and he will also have a list of the unanswered questions from this webinar that he'll have as a reference as well. I think there's some good content coming up there, right, Omar?
Yeah, exactly. No, I've got some interesting questions here. One was about how long I leave calcium hydroxide inside the canals before the obturation, and the general view on that is at least 1 week, but as much as 3 weeks is ideal. There was a study recently by Rikuchi who looked at that, and the longer you leave it in there, as long as it's sealed, but then we're relying on the temporary restoration to seal it.
Omar, I'll just make sure that we don't duplicate on the questions here, and I'll just steal a quick minute from this here to share a little bit of some of the resources we have that might be useful for our participants as well. And these will be shared in your chat here. So very quickly, we would like to invite you to join our following webinars. Our next one is in 3 weeks about tooth whitening with Dr. Adrian Go. And or if you don't mind, I'll just share my screen real quick, and I'll ask you to share back, and then we can come back without the screens, if that's okay with you. I'll just go real quick here. And we have the next webinars coming up. Here, as you can see, and then that you have access to this. This is the full program. I won't spend too much time here. Again, I want to take advantage that we have Dr. Ikram. Some of you asked about the app that he used to find the canals. So you will find this in Dr. Ikram's profile on Instagram, EndoPrep. Okay, so I've shared the link on the chat there as well.
Thanks.
Yeah. Oh, of course. And we have the UltraDent blog, en.ultradent.blog. If you want to check out, different articles about endodontics, restorative dentistry, tooth whitening, many different subjects. Every single week there is a new article posted there. And we also have our free continuing education site at educationmadeaccessible.teachable.com, where we have pre-recorded webinars, including from a previous one from Dr. Ikram on a slightly different subject here, that you can register and join for free. And upon completion, you will also receive a certificate that, depending on the course, depending on the country, it is valid also for CPD. Okay? If you have any questions, you can reach us through there. Also, be sure to follow UltraDent. If you're in Asia, it's UltraDent SEA. In Australia and New Zealand, UltraDent ANZ. In Africa, UltraDent Africa, or again, any other region, UltraDent teams will be happy to interact with you. So sorry about that little intermission there, and I think we're ready for the questions now. And let's see how many of them we have. So 136. All right. It'll be a long night, but again, we'll do our best here. We have a question here that's been uploaded 31 times, so let's start with this one. When you're irrigating the canals, how do you use EDTA and sodium hypochlorite? Do you need to use one before the other? You mentioned that the sodium hypochlorite degrades the EDTA. Thanks.
Yeah, that's actually quite a good question. So I actually use EDTA right at the end of the preparation to remove the smear layer that I've created. If you think about the way that sodium hypochlorite removes the organic smear layer and EDTA removes the inorganic smear layer. The only thing that hypochlorite doesn't do very well is remove inorganic tissue or organic products. So the smear layer, so that's what EDTA does. And basically, I would use it after so I clean up all the canals, sodium hypochlorite all the way through, and then I gauge the apex and maybe do some hand filing, and then I'll use my EDTA, and then I will actually remove the EDTA and do a final rinse through with sodium hypochlorite, because I want that sodium hypochlorite in the lateral canals, and I want it to go towards the biofilms. I don't want to just remove the smear layer and have had a smear layer on the full time when I've been using sodium hypochlorite. So I use it just as my penultimate irrigation.
Excellent. Thank you. The next one from Dr. Jenny Wong. IOR, how long do you usually leave calcium hydroxide inside the canals before the obturation appointment?
Yeah, so this is the one I just said before. About at least a week, probably up to about 3 weeks is optimum. You're really relying on the seal of the temporary. If you could seal if the temporary could seal for a long time, then we could say that would be longer. But in general, it doesn't seal for more than a couple of weeks, 2 to 3 weeks. So I'd say jump in there. It depends on the situation. Like an occlusal access is easy to seal. It's easier to seal for longer than, say, a tooth with a root surface defect and trying to seal that. In cases where I'm trying to seal difficult to seal areas and I'm wanting to temporize, I will tend to use IRM, which is a really good temporary material to prevent bacteria getting into the root canals. But normally I would just use grey cabot if I'm not worried about the seal.
Thank you. Our next one in line here, Dr. Sandra Lam. If you can see a crack line running down the distal wall of the pulp chamber but not through the pulpal floor, is this an indication for extraction of the tooth, or can root canal treatment be considered with a medium-term prognosis, 5 to 10 years?
This is a really good question. There was a recent study by Davis and Sharif on this, and they looked at cracked teeth, but they were talking quite short times, and they looked at teeth with fractures and even periodontal pocketing, and found that they were able to preserve these teeth. But we are talking 2 to 4 years, and that, in my opinion, is not that long for many patients, especially if 2 years later they need an implant. It depends on the circumstances of the situation, obviously. And for some patients, 2 years might be fine, but in others, mostly it's not. So when I see a crack running down the wall, I will try, the way I treat these patients are, firstly, if there's no periodontal pocketing, I'm okay to proceed. If there's periodontal pocketing, I'm more likely to recommend extraction as an option. I think with these cases, it's really important to realize that we need to realize these are options for the patient, not you have to have the tooth out or you have to do this. You relate it to the patient, and I had a case just last week. The patient, 4'7", has a crack in the root. We took a cone beam because I noticed something on the PA. There was a defect distally in the bone, and I looked at the opposite side, and there was no defect distally in the bone of that tooth. Now, it could have been the wisdom tooth that had been removed a few years back. I'm really not sure, but this tooth had an obvious defect where the fracture is, and I took a cone beam, and it showed quite clearly. So I just said to that patient, look, if I was you, I would probably consider possible replacement of this tooth. And in his situation, it had to be an implant because there's no other bridging tooth. There was no 8 present, so it's just a 7. And you could consider that. Now, if the person who's doing the implants comes back and says this is not an option, it's not good, or it's not going to work for you, or you decide that it's not going to work for you because of whatever reason, then we will investigate further because you have this defect. So this is what I'll do. The other scenario, let's just say the tooth looks like it could be saved, hasn't got any pocketing, and the fracture is definitely there, but it's not too severe and there's no periodontal issue. Then I will open up the tooth, look inside, visualize the crack. If I can see the crack is open coronally, but it is a line or it's not open down the root, then and it hasn't got pocketing, I'm okay to do the treatment. If it looks like it's open down the root, and you can usually see with a microscope with a black biofilm, then I tend to suggest extraction. Again, you medicate the tooth, and the other thing I like to do is medicate the teeth for long periods of time, 2 to 3 months. Put an orthodontic band around to stop the crack from propagating and seal them, and just basically close them, and then say to the patient, can you chew on this tooth in like 3-4 weeks? If you can, and your pain is gone, that means that the root canal is sealed by the band and the temporary, and it's closed. If you get reinfection of the root canal down the line, then you've got a crack that's opening up and letting in microbes, and this will happen whether we root fill the tooth or not. So, and then you would opt for extraction possibly. There's a whole lot of ways I treat these cases. I've done some articles on these as well, but that's basically in a nutshell what I do. Tell them to go for a long time. IRM is my temporary base, and then GIC on top.
Thank you. We have one from Dr. Peter Norton. Do you have any concerns that pre-appointment ibuprofen might mask the signs, symptoms you need for a good diagnosis?
This is possible. So I think that that's a good point. This is where the fast-acting ibuprofen can be handy to have in your surgery, because if you do tell the patient to take it home and they turn up and there's no pain, then you're in trouble. But it probably isn't going to affect the tests hugely, because it's just a decrease in the sensitivity. It's not the removal of the entire sensitivity. But this is certainly a possibility. So if you're worried about this, then just get them to take the fast-acting ibuprofen when they come and you've done the tests.
Thank you. Next one from Dr. Mary Zaki. Any tips for anesthetizing hot pulp in upper molar?
Yeah, the upper molar is much more readily anesthetized. I would definitely give an infiltration and both buccal and palatal on these patients. I've recently taken to using the Septidon dental pen for infiltration on the palatal aspect, and it's very good. It basically deposits a slow release over a couple of minutes, so the sort of recommended speed that you're supposed to inject that, and that certainly helps with anesthesia. So definitely that, and then also the intraligamentary is another option here as well. But it's actually far easier to anesthetize an upper molar with a hot pop than it is a lower molar.
Thank you. Again, just a quick reminder, if you see a question that might be your question, make sure you upvote rather than entering a new question, because we might not get to the end of this list today here. Next one is, hey doctor, I have a problem of using the endofrost to do the cold test. And I placed the cervical area of the tooth using cotton pellets held by a tweezer or sometimes cotton bud. I find the patients don't respond, even for the control tooth. May I know what is the cause, or how do you do the cold test?
So the cold test with endofrost, you need to guard the buccal gingiva with your mirror or your hand, or gloved hand, to stop the patient feeling the cold vapors on their gum, the gingiva. When you apply the cold to the pulp horn areas, so apply to the region of the tooth where the pulp horn will be sitting. So think of your root canal arrangement and say an upper molar tooth. You're going to have the MB root canal close to under the cusp of in the middle region of the cervical region of the tooth, under the MB cusp. So apply the cold to this region. If you don't have a positive response with cold, and also for the controlled teeth, the patient may just have calcified root canals. Unfortunately, if the patient doesn't respond to any of the tests, the cold testing, you would probably have to try an EPT test. The problem with an EPT or electric pulse tester is that basically they are open to false positives in a major way, because the patient can get firing of the electrical signal through the periodontal ligament, and also it can go onto other teeth that are vital when you're testing a tooth that's got a necrotic pulp. So that there are issues with using EPT, although it's the next test that we use in line. So cold is the most reliable, and then EPT is very close to that. Hot is not reliable at all. So you can't use a hot test unless the patient tells you they've got pain on hot, and then it's a test. Otherwise, it's not a test to use. So to answer the question, basically you can't use the test if you can't get a response on any teeth. You have to go off radiographs, patient history, palpation, tinnitus, percussion, all the other tests. Cone beam is obviously an option with these teeth as well. So sometimes I'll resort to cone beam. It's not clear. If you can't get a response with cold on any teeth, there's no apical disease on the radiograph, if the patient reports pain and it's not easy to elicit the pain, then you've just got to go for cone beam and hope that shows some changes. The other thing is wait and see what happens. Come back when it's worse. You do have to sometimes tell patients that I'm pretty sure that your tooth it's that tooth, but we really don't have enough evidence today to show that. So come back if it bothers you, and sometimes they come back a few months later, and then it's more obvious.
Okay. Next one, Dr. Imelda saying, hello, what is the best way to drain the abscess?
Use a scalpel.
Okay, that was quick. Next one, what if even after intraligamentary and intrapulpal still not numbed? Many cases like this, even after course of antibiotics.
Well, so they have trouble with anesthesia after antibiotics. So with trouble with anesthesia, the other thing to remember is that there is a possibility you can use some kind of inhalation sedation, or if you're able to get your doctor to prescribe a sedative, this will help the patient. Often this is a factor as well. Sometimes you just get patients who jump around and they're not feeling pain, they're just feeling pressure and movement. These patients are the ones that are really good for sedation and nitrous oxide or IV sedation. I do that more and more, I find, because in endodontics we're doing microsurgery of teeth. In fact, today I just had a patient, I was on the border of thinking that I would need to do it, but we were okay. We got there to hold the suction and stuff, but a very difficult situation. And with endodontics, you really can't be doing compromised treatment. So, I find more and more that I opt for IV sedation. I don't get that many patients, obviously, that I can't anesthetize. So if you're having if you've got a patient who can't be anesthetized and they're taking antibiotics, maybe it's not the antibiotics, and maybe you just try them on ibuprofen beforehand and use the tips that I've suggested in the talk.
Thank you. Dr. Tori Petty, how do you negotiate and instrument canals where they're calcified in the apical third?
This is a great question, so thanks for asking it. So basically the teeth that have calcifications in the apical third, my go-to is to open the coronal part of the canal as much as possible. So go to where you can get to with a rotary, something as small like a shaping file. Don't go for obviously large finishing files. Just something that's going to flare the canal. You need the tip of that file to work down the canal. You don't want the file to be held up at the coronal part and you're trying to struggle against that restriction coronal. So this is why I suggest getting the shaping file down as far as you can, conceivably. And then I will go to the C-pilot files, which are essentially stiffened K files, and work these files. These don't have a cutting tip because they are stiffened K files, which don't have a cutting tip. That usually works most of the time. So I'm talking about the small sizes, the 8 and the 10s, and sometimes even the 6s. Now, if they start to buckle and bend, then I will go to my what I describe as my last resort file, which is the C+ file. And C+ file is a stiffened cutting file. It's got a square cross section, so it's very similar to a K file, but it's tapered. So it's a tapered. So you have the six C plus file is a nice file if you can use it, because it has a size 6 tip, and then the next diameter after that, so 1 millimeter back, it's a size 11, and then 16, and then 21. So basically you have like a very tapered file, and basically it's very, but it's very stiff because it's very tapered. So it has its disadvantage, but it cuts. So the C plus file is very useful for when you've got a total blockage at the apex and you're just trying to get down the end.
Now, the next up here, Dr. Kathy Song. Does time between appointments vary depending on your diagnosis? Shorter or longer if the patient had a symptomatic irreversible pulpitis as opposed to an acute apical abscess?
Well, I think for patients who have got abscesses and there's been a lot of pain, you need to really resolve that. But fortunately, you usually do by incision and drainage, and it would be rare that you would get the patient coming back with an abscess again on this next visit. So I would say generally the appointment time would be similar. I think if it's a irreversible pulpitis, I'll be more keen to get them back. I try to do irreversible pulpitis cases in one visit, but we don't all have the time for that. Because, like I said, if you take out the pulp tissue and the bacteria, then you fill it up, and there's no or minimal inflammation apically, or no inflammation apically. When you've got other scenarios like symptomatic apical periodontitis and an abscess, then you have inflammation in the periapical tissues. So basically, I would opt for a similar amount of time. I'd say 2 to 3 weeks is a good time period.
Next up, Dr. Kelsey Stokes, can you use EDTA instead of citric acid for cleaning pulp chamber? Also, what are your thoughts on using alcohol to clean the axis after obturation? And there's a comment to it from Dr. Elizabeth too, saying thoughts on using etch to clean the axis.
Yeah, so you can use etch, you can use EDTA, you can use alcohol. Alcohol is useful for zinc oxide eugenol sealers because, of course, the eugenol is supposed to affect the bonding of composite. And for that reason, I don't use zinc oxide eugenol sealers anymore. I used to like the idea of them being antibacterial, like your IRM that I described is also antibacterial. But the problem with that is that inside the root canal, it's not quite as desirable. Well, it's okay inside the root canal, but when it's extruded, it's not quite as desirable. Because when you think about it, if you've got an antibacterial effect that goes on for a long time, like zinc oxide eugenol does, that's not going to be that good for the patient's tissues. So you want a sealer that has a short antibacterial action, maybe while it's setting, like an epoxy resin is a good type of sealer, or even the bioceramic sealers release calcium hydroxide for a short time, and then when they're set, they don't release any further products. So I would say, yes, you can use alcohol for cleaning the pulp chamber, but that's only to remove zinc oxide eugenol. There is no other reason. I don't use alcohol to clean the pulp chamber. The citric acid or the etch, the citric acid is very, very effective, as you can see from the pictures, and that was very quick. Etch is one, and EDTA is used throughout the procedure anyway. So, yeah, I mean, you can use all of these. They're all acidic.
Dr. Ryan Long, with hot pulp, if after intrapulpal still can't access due to pain, I've heard where people leave the cavity open overnight to let it drain and lower pressure and bring them back next day to address. What's your take on this?
I haven't heard that for pulpitis cases because pulpitis is primarily from inflamed pulp and bacteria coming through a defect. I have heard that for abscess cases or swellings to allow drainage of the swelling through the root canal. But the problem is that if we leave a canal open, we just complicate the microorganisms in the root canal, and it leads to a possibility of the patient getting caries in the access. There's a whole lot of problems for leaving teeth open. In general, I won't leave teeth open. I'm not a fan. So I don't do this. What you could do is, again, suggest ibuprofen preoperatively. Try again another day. It might be, if you have a situation where you do find it difficult to sedate the pulp and you're really struggling, and you get into the canals and you're still struggling, then this might be a situation where you might use a steroid antibiotic paste, because this could help. So that's what I did used to use, steroid antibiotic paste, but I haven't used them in years, mainly because my anesthesia is better and I have more time now to do endodontics. I don't get many emergency cases because I'm not in general practice. The general practitioners get these emergency cases all the time. I get emergency cases, but they have got a history when they come to see me. They've had their deep filling, they've seen their dentist, the dentist is concerned, they call the practice, and the nurse, reception staff and nurses fit the patient into a decent time slot. I don't get them turning up and needing a half an hour extirpation. So this is where I think that basically it's a good idea to possibly either refer the patient or sedate the pulp with some antibiotic steroid paste and paste and try again, or ibuprofen, or in relation sedation or some other sedation technique just for that first visit, maybe to get them through the pulp extirpation.
Great. Thank you. Next here we have our first odontopaste question. If you dress with odontopaste, do you then have to redress with calcium hydroxide before obturation appointment?
Look, I think it depends on whether or not you are removing lots of pulp tissue or was concerned. If I was concerned that I was not able to get all the pulp tissue out and it was a difficult anatomy, then I probably would use calcium hydroxide and then try again in another visit. Because, as I said, bacteria love the pulp tissue in the tooth. If you leave pulp tissue in the tooth, it essentially makes it food for the bacteria. They regrow it and they cause apical peritonitis. We're trying to create a state of starvation or famine within the root canal. This is what our aims are. It's a little bit lost on many of our studies and just the general teaching of endodontics that we're trying to kill bacteria. Yes, we're trying to kill bacteria, but how do you get rid of animals? You remove their food source. Very easy to get rid of animals quickly if you remove food source. It's happening all over the world right now. Much more difficult to take a bulldozer and start knocking them over and destroying the population. That's much more difficult, although we're doing pretty well at that in the world at the moment as well, the human race. But much easier to take away something they need and then slow their existence down. So that's what we're trying to do. So I think both removal of bacteria and creation of starvation. So try and do that. Aim for that kind of technique, and you'll be happy with your endodontics.
Thank you. We're past our time here, and shall we go for a few more questions?
Yeah, do another 10 minutes.
Okay. Oh, wow, great, sweet. So let's go for it. Again, okay. I'll just even say anything. Let's go straight to them. So, Dr. Yusuf Agogi, for pulpotomy, can the vital pulp be washed with sodium hypochlorite or only sodium chloride? Sodium hypochlorite may cause coagulative hemostasis, not physiological. Any ideas, please?
Yes, so you can wash it with sodium hypochlorite. There's no problems. I don't use a high percentage. I'll use 1% if I'm just washing to do a pulpotomy. I'm not trying to remove pulp like down the canal. I'm just trying to get rid of the bacteria and clean the coronal pulp.
Okay. Next one. Why lignocaine for lingual infiltration instead of articaine?
Good question. You could use articaine, I guess, but look, articaine is a safer anesthetic because it's metabolized in the plasma, not the liver. And the dose that you can give that takes you to overdose is a lot more than lignocaine. So articaine, you could use it. I don't know. I just feel that that's heaps more anesthesia than you would need. You've given a block with articaine, you've given a buccal infiltration. there is no evidence that giving a lingual infiltration with articaine is that much more effective. When you think about it, you do deliver a very dental block with articaine, you will get lingual anesthesia anyway. It's merely, the reason why I do that is merely to just make sure that the patient's completely anesthetized. The other reason is you take radiographs, and you don't want the patient saying after that you've given the anesthesia that the radiographs are uncomfortable, the clamp feels pinchy and things like that. You just don't want that. And so you could use articaine infiltration if you want to.
Thank you. Next one, Dr. Gianmarco D'Andrea. How can we prevent flare-ups during root canal treatments? I've seen some patients who are in severe pain following the first appointment. I am assuming it is due to extrusion of canal debris. Hypochlorite injury was ruled out.
Yeah, look, so this is the phoenix abscess that I spoke about. I actually had one of these patients a few days ago. Look, if you treat the patient in one visit, which is what I did, and it was a retreatment, so that's a possibility. There's a couple of things you can do. First of all, try not to extrude during preparation, but that's pretty hard. Wash the root canals as much as you can before you get to the apex. So crown down technique. So removal, irrigation, removal of GP irrigation, or removal of pulp tissue if you're doing a vital case or a necrotic case. Try to avoid extruding dental debris, and give the patient a lot of post-operative information, like it's going to be sore, and yes, it might swell. And look, you prescribe them ibuprofen. As I said, you can use 600 milligrams of ibuprofen and 1 tablet of paracetamol. This is better than an opioid tablet. It's better than antibiotics. We know that. Now, the other thing you can do is just give them that time period that I talked about, the 6 days, and give me a call and all that at this time and this day. And you would be amazed about how many patients they send you a picture of their tooth saying or their gum or their gingiva swelled up, and say that the tooth hurts now. And you say, yeah, but you've got to give me a call on Wednesday at like 12 o'clock. And they say, okay. And so what I do is I make an appointment on Thursday and say, come in on Thursday at like 3, but give me a ring on Wednesday at 12 if you still need that appointment on Thursday. And they feel good about that because you've got an appointment in the diary. They're not going to be waiting for weeks to see you. They're worried, but they're not worried once they have the appointment, and you've told them it's going to be okay. And you would be amazed about how many patients either ring and cancel and say everything got better, or I will come to the appointment on the Thursday and say, hey, you know how it was really bad? I showed you the picture and stuff, and I said yes. It's kind of better now, and you would be amazed at how many get better in a week, because it's essentially just like a tissue injury. And it's inflammation, and inflammation, as we know, in a closed environment, inflammation takes about a week to 10 days to resolve, because it's like a pain that you get. If you have infection, this is different. When you've got an infection coming in and stopping the healing, then this is the problem. And this is the problem with a lot of endodontics. Obviously, that's the infection coming in, and the pulp is always inflamed, and then it's a big issue. But if you have a closed environment, like it's a well-done root canal treatment, you've cleaned it out, there's some inflammation in the tissues, there's nothing going into the tissues because the tooth is sealed and everything's sealed, the gingiva is sealed, you're going to get resolution in 7 to 10 days.
Next one, when performing root canal therapy on a tooth with an associated sinus tract, do you need to do anything differently than if there was no sinus tract?
Look, this is a great question because, like, I've read lots of papers, Ning, Rikuchi, various papers that show that sinus tracts have a lower success rate. And I totally agree. Like, if you're complicating the endodontic disease with a periodontal issue, essentially, you've automatically got a periodontal issue if you've got a sinus tract, and it might be a minor one, but it's another tissue involvement, and it's an open area, like we just talked about a few seconds ago. This open situation, you had a closed inflammation and the swelling. That's fine. It's when it's open and there's things going on and there's more dynamics going on there. So I would almost always treat not always, but almost always treat sinus tracts in multiple visits. The good thing about sinus tracts is when they get post-op pain, they don't get post-op pain, they get drainage of the inflammation through the sinus tract. So you say to the patient, you're probably not going to get much pain. It might be a bit uncomfortable, but the good news is the inflammation will drain through the sinus tract for a few days, it'll heal up and then probably close. And I give them about 2 to 3 weeks for that to heal and see them again. So I would treat in multiple visits, more likely to treat multiple visits with sinus tracts than if there was no sinus tract. In fact, if there's no sinus tract there, I'm more inclined to treat in one visit if I have the time. But I probably won't treat if there's a sinus tract in one visit. I'm less likely to.
Okay, thank you. Next one, if tooth is still slightly tender to percussion weeks after observation, no other symptoms, is that an indication to monitor tooth further before playing for chapel coverage?
Cuspal coverage.
Yes, cuspal, yes.
So the answer to that question is that you need to work out why the tooth is tender to percussion. There's so many reasons why it can happen. It's not just going to be root canal disease. Tenderness to percussion is a sign of inflammation in the periodontal ligament, but it's not a sign of root canal disease. In fact, patients that come back and say my tooth is tender to percussion, and that's the test you used to test the tooth, I say yes, but it's a poor indicator of root canal disease. It could be food impaction, it could be clenching, it could be so many things that cause tenderness to percussion. It's really, it's not really a diagnostic test, but it's just one of the tests we use. So my advice on that is get the diagnosis right. I have had patients with periodontal defects who have tenderness to percussion, and they have needed periodontal treatment, and then it gets better, or improvement of the contact of the restoration, or they're clenching on the tooth, and things like that. So these are all possibilities. So the diagnosis needs to be correct. Basically, if a root canal treatment's done well, you find all the canals, clean it out at the end, the chance of healing of endodontic disease is high. It can take time, and if the patient does clench and grind their teeth, the healing will be slowed. No doubt, if you've done a root canal treatment and they need healing of the periapical tissues and they continue to hammer the tooth, the healing will be slowed. So maybe just monitor, but it really depends on the diagnosis.
Thank you. Dr. Yusuf Gog, can the air bubble effect be seen through the dentine over the MB2? Yes,
that was the slide that I showed.
Yes, and there were some other questions down the road there about the bubble.
It's hard to see, but you have to use magnification. That's one of the few tests that you do occasionally, where you definitely need almost certainly need a microscope, or at least I would say at least 5 times magnification. Otherwise, you just won't see it. You won't see where they're coming from.
Okay. Shall we go for the home stretch here? Maybe 4 more questions?
Sure.
That's
sure,
okay.
Yeah.
All right. Thank you. So next one, what is the best way to deliver intracanal medicaments?
I like the Navi tips because they inject the calcium hydroxide down the canals, and then activation if you need to. Like, so say you saw the video, my stopper wasn't reaching the reference point. That was set about 1 to 2 millimeters from the working length, so that I don't extrude calcium hydroxide. If that doesn't reach the reference point, then I'm definitely going to use either a file or an activation tip, endo activator or the IDI, which is what I showed, the IDI going around. You can use that just to activate the calcium hydroxide down the canal, because it works best if it's in contact with the biofilm and the whole root canal rather than just the coronal part.
Okay, thank you. Next one, for a patient with a hot pulp who cannot take ibuprofen, is there any other medication that they can take pre-operatively to reduce pain?
That's a very good question, and so thanks for asking that. So yes, you can take paracetamol and codeine. That's probably the best combination. But again, codeine carries the sedative effect, and you're not supposed to operate machinery and drive cars and stuff like that. So yes, paracetamol may help, but it's not going to be as effective.
Then when would you give up looking for MB2? Like that.
Yeah, so I've been asked this question heaps, and the answer, funnily enough, isn't to do with time. It's got to do with what you see. So today I had a patient who had no MB2, but it had a fin. So what you do is you see the MB1, you treat that, you trough laterally, and you see that there's a line. And in that line, you put a file, and the file touches the line, which is the canal, obviously, and it skids into the one you've just prepared. So this is what you need to see to give up. Because if you just see a round canal that you've prepared and nothing, then there's probably another canal there. You need to see that shape that shows you there should be a canal there, but it's joining the MB1. That's when I would give up. You have to see. Today I had a case with the figure 8, the one that I showed the last with the citric acid, and a figure 8 shape in the distal. And again, it had 2 canals, and you can see that on the radiograph when I took the working length radiograph. It had I wasn't in the center, and there was definitely 2 canals. They troughed across, and then I looked down the scope and saw that figure 8, and then I knew I was good because I had the 2 canals. They're just in the figure 8 shape. So you need to see the anatomy of the architecture of what you want to see before giving up the chase for the second mesobuccal canal. So if you see a round canal and nothing, then I'm really inclined to keep looking. If you see that teardrop shape, then that's probably the MB2 just blending into MB1.
Thank you. And finally, how would we assess cracks to the pulp chamber and their success rate following root canal treatments?
How would you assess that? So, well, first of all, periodontal pocketing is a big issue. If there's toxins coming out laterally, then you'll get periodontal pocketing. So you need to use, there's a few techniques. You need to use radiographs, possibly CBCT is an option. There's some cool things coming out with CBCT soon, if not already. Bruno Azevedo, he's doing taking out beam hardening and doing a few things where you can see cracks better. So this is a new technology that's coming out. So this might be something. So I think imaging, radiographs to show periodontal defects, they generally don't show cracks. And if you can see a crack on the radiograph, it's a good problem. Because the beam, the electrons have passed through the crack and exposed the film. That's got to be a pretty decent sized crack to do that. Then you've got CBCT and you've got your probing. So another little tip is anesthetize the tooth and probe with your perio probe hard around the tooth once the tooth's anesthetized. And if you get drops of like 5 to 6 millimeters in areas where the crack is seen, that's a bad sign. Probing the patient before they have anesthetic is always a bit difficult. So that's something to be wary of. And often you don't get the right angle, and often you can't push hard enough. So just give it a good probe around. And if you don't get defects, then that's a good thing. But you need to match the probing, the images, and that's how you assess. That's how you get. That's how you basically choose what to treat. And again, the patient's symptoms. Medicate the tooth, IRM, temporary, and close it up and monitor the symptoms of the patient and get better. They've got an open fracture somewhere, letting in fluid, and it's getting reinfected. If it clears up the whole problem for, I usually say about 6 to 8 weeks, or it's around that period, then I'm happy to finish the treatment. Sometimes I even get the patient back and they say, oh, it's been a bit funny. And I say, do you want to keep the tooth or not? I mean, it's up to you now. We've tried our best. And sometimes they say, just go ahead and finish it and it should be okay. And other times they prefer to have the tooth out. So again, this is the advantage of treating patient in multiple visits, is you get the patient along the way and they make choices depending on what they feel like. Because obviously it's their tooth. So this is a really important thing to allow them to do. Single visit on teeth that are cracked is really, really difficult, because if it's all finished and the tooth's still a problem, then what do you do? Take the tooth out, unhappy patient. So treatment in multiple visits for cracked teeth almost always.
Thank you. Dr. Ikram, once again, I really want to thank you. There are over 1,000 of us here still that would probably stay all night long, all day long, depending on where we are, and just listening to you. This is so informative, so broad. You know, it's so refreshing to listen about endodontics. All of it, of course, is interesting, but it's usually mostly focused on instrumentation, and it's good to escape from that core topic and address so many different issues as you have here today. I appreciate all the effort that you've put together into making sure that this is a fresh and new and exclusive presentation. And I know how much you've prepared for this, and that's just a sign of the passion that you always show every time you get a chance to talk about endo, and I really appreciate that. I really thoroughly enjoy just listening to you, either through this or just chatting. Again, I would like to invite all of you to follow Dr. Ikram on Instagram and Facebook. His content is just phenomenal, and again, he's very accessible. And as I said, as I promised here, we have 158 open questions still here. There's no way on earth we would be able to get through everything, but I'll forward them to you, Omar, and we will be in touch as well. Many of you have asked about a recording about this presentation. I would also like to invite you to, again, check back on or onward and upward page, but mainly on Specialist Endo on Instagram, because the announcement of when that will be available will come through there. Okay, so stay tuned. And yeah, I think, again, thank you really so much for the massive comments that you have. We will send you, for those that stayed throughout, of course, that Zoom will tell us that participated, we'll send you the certificates. And you can reach us at info.apac@ultradent.com. And I think there are some links that have just been shared here on the chat if you want to check it out. With that being said, I would like to wish you all a great rest of the day or a good evening, and especially to our speaker today, Dr. Ikram. Thank you. Thank you so much for just enlightening us and for being so generous with your time and being so passionate about teaching us and answering all our questions, most of our questions.
No, thanks, guys, for inviting me, and thanks to everyone for listening, because it's not an easy thing to come down from your surgery and take time off and give it to education. But you, as I said, you guys have done it for yourself and for your own patients, so that's very admirable of everyone. And thanks, Fabio, for being a great host.
Thank you. All right, bye-bye, everyone.
Okay.